Everybody, today we are going to discuss regarding benign bone tumors. Benign bone tumors. Okay, so benign bone tumors are diverse in morphology and biological potential. Most bone tumors are benign. Most benign lesions are seen below 30 years of age. A new bone tumor in the elderly more likely is to be malignant. A new bone tumor in the elderly is more likely to be malignant than benign. And no bone is safe. The bone tumor can occur in any bone. The location in the bone depends upon diagnostic information. And more common benign lesions they typically present with incidental findings. Okay, pathological fracture can also be a first sign of a tumor. So bone neoplasms are very difficult to diagnose specifically based on radiological testing. So why radiology is important? Because to know the exact location of the lesion, extent of the growth, metastasis, and its aggressiveness. So best test for diagnosis is primary test is X-ray. For staging, it is CT and MRI. CT and MRI. And the most important prognostic feature for any sarcomas is the histological grading. Histological grading. So here you can see the different locations of the bone tumors. Okay, so here you can see the fibrous dysplasia is common in the diaphysis. Osteoid osteoma is common in the diaphysis. Chondromyxoid fibroma in the metaphysis and adjoining diaphysis. Osteosarcoma most common in the metaphysis. Osteochondroma most common in the metaphysis. Bone cyst common in the metaphysis. And in the epiphysis, most common, as we have already discussed, the epiphysis most common is the giant cell tumor and chondroblastoma. Giant cell tumor in skeletally mature and chondroblastoma in skeletally immature patients. So benign tumors are classified into one bone forming tumors, cartilage tumors, fibrous tumors, cystic lesions, fatty tumors, and vascular tumors. So one bone forming tumors are osteoid osteoma and bone islands or inostosis. So cartilage lesions are chondroma and osteochondroma. Fibrous lesions are non-ossifying fibroma, cortical desmoid, benign fibrous histiocytoma, and fibrous dysplasia, osteofibrous dysplasia, desmoplastic fibroma. Cystic lesions are one unicameral bone cyst or simple bone cyst, aneurysmal bone cyst, intraosseous ganglion cyst, and epidermoid cyst. And fatty tumors are lipoma, and vascular tumors are hemangioma. So for any bone tumor, the preliminary investigation is the X-ray followed by staging of the tumor by CT and MRI. MRI is also is taken to know the spread of the tumor if there is any cortical breach. Okay, so technetium bone scan is used to know if there are any occult sites of any tumors in the body. Okay, so three stages which follow IV injection of a tracer. So what we do is in bone scan uh, we have we make use of this technetium methylene diphosphonate as an active agent. So there are three stages. One is flow phase, blood pool phase, and delayed bone phase. So flow phase is after 2 to 5 seconds the images are taken. For 60 seconds after injection we give this injection contrast radioactive dye. So radioactive dye by IV injection, and then we take an X-ray. 2 to 5 seconds after we take an X-ray. Demonstrates the perfusion and characteristics of blood flow to a particular area. Okay, so blood pool phase is taken 5 minutes after injection. 5 minutes. X-ray is taken 5 minutes after injection. Okay, so delayed bone phase is taken 2 to 4 hours after injection. 2 to 4 hours. X-ray is taken around 2 to 4 hours after the injection of this IV radioactive dye, that is technetium. Okay. So FDG PET, what is FDG PET? What is PET scan? PET scan is uh, uses chemical called fluorodeoxyglucose. Fluorodeoxyglucose emission tomography. So positron emission tomography uses radioactive glucose to locate the cancerous tissue. Okay, to locate the cancerous tissue. So radio labeled biocompounds, 2-fluoro 2-deoxy glucose is injected IV intravenously. So uptake of this compound followed by further breakdown occurs in the cells. The tumor cells have higher metabolic rate, so that's why this compound is metabolized by the tumor cells. So FDG is metabolized to FDG 6 phosphate, which cannot be further metabolized by the tumor cells. So hence it accumulates and concentrates in the tumor cells. So this accumulation is detected. This uptake is detected in the PET scan. PET scan. Okay. So next most conclusive test is the biopsy or histopathology. Histopathology. Okay. So types of biopsy are one needle biopsy, fine needle aspiration biopsy, core needle biopsy. Okay. Incisional biopsy. Okay. So these are the types of biopsy. So next comes the staging. Staging is done by Enneking. Enneking describes the most widely used staging system for benign tumors. Stage 1 is latent, stage 2 is active, stage 3 is aggressive. So stage 1 latent is low biological activity. It's a well marginated tumor. Is often incidental finding. It may resolve spontaneously. Okay. So type 2, stage 2 is active. Active is symptomatic. It has a limited bone destruction, may present with pathological fracture like aneurysmal bone cyst. Okay. Latent example is non-ossifying fibroma. So aggressive tumor, it causes bone destruction, soft tissue extension, requires complete workup, removal of wide margin resection has to be done to avoid any possible local recurrence. For example, it is giant cell tumor. So for malignant tumor, adopted musculoskeletal society, or there is a separate staging which is Enneking staging. It has a stage 1, stage 1A, stage 1B, stage 2A, stage 2B, and stage 3. Stage 1A is based on histological grade, it is a low grade, and based on the extent it is intracompartmental and there is no metastasis. Stage 1B, it is low grade tumor, it is extracompartmental spread and no metastasis. Stage 2A is high grade tumor, intracompartmental and no metastasis. Stage 2B, it is high grade tumor, extracompartmental, no metastasis. And stage 3 it is any grade and the local extent can be anywhere. If there is a metastasis, it is stage 3. Okay. So next, Campani's staging, radiological grading system, better for prognosticating the aggressiveness of the tumor. Used for giant cell tumor. Grade 1 is it intramedullary. Grade 2 it is thinned cortex. Grade 3 it is cortical break. So surgical principles are one. The surgical margin is described one of the four items. One, it is terms. It is intralesional. 2, it is marginal. 3 is wide local resection, and 4 is radical resection. So how do you resect the tumor? Intralesional resection means the plane of the surgical dissection is within the tumor, which is called debulking. So marginal resection is when the plane of dissection passes through the pseudocapsule. It is marginal resection. So you can see here the tumor is here. If you do an debulking, it is called the intralesional resection. Marginal resection is you remove slightly through the capsule of the tumor, only the capsule of the tumor. Wide resection is you remove around 1 centimeter of the normal tissue around the tumor. Radical resection is you remove the entire limb of the tumor. Okay, that is radical resection. So wide local resection is achieved when the plane of dissection is in the normal tissue. Normal tissue. Radical resection is where all the compartments that contain the tumor have to be removed and blocked. That is radical resection. So the another this thing is curettage, simple curettage, extended curettage. Simple curettage is a cortical window over the lesion. The bulk of the tumor is removed. Cavity is filled with a cavity is enlarged back to normal. The host bone in each direction with a power burr, and it is copiously irrigated to remove any debris or tumor cells. Extended curettage is by use of any adjuvants, adjuvants like liquid nitrogen, phenol, polymethyl methacrylate, and cautery. Cartilage lesions are one osteochondroma, chondroma, and enchondroma, and periosteal chondroma. As we have already discussed osteochondroma, now we will proceed to enchondroma. Enchondroma. Enchondroma is a common benign medullary cartilaginous neoplasm. Okay, it is most common seen in children, 3 to 10% of all the bone tumors and 12 to 24% of all benign bone tumors. It complicated by pathological fracture or malignant transformation into low grade chondrosarcoma. Okay, so clinically, if enchondroma is painful in the absence of a fracture, it should be considered malignant. Enchondromas, they arise from the growth plate, cartilage chondrocytes that subsequently proliferate and slowly enlarge and composed of mature hyaline cartilage. They are seen in any bone formed by cartilage. Two syndromes which are associated with multiple enchondromas are one Ollier's disease and Maffucci's syndrome. Maffucci syndrome, Maffucci syndrome. Enchondroma is most common in bones of hands and feet. 50% of the enchondromas they occur in bones of hands and feet. Large tubular bones, femur, tibia, and humerus. So rarely an enchondroma may extend through the cortex and demonstrate exophytic growth pattern. Rarely. Okay, almost all the enchondromas are located in the medullary cavity. So differential diagnosis is bone infarct, chondrosarcoma, intraosseous ganglion. Okay, so here you can see typically enchondromas are 1 to 2 centimeter lytic lesions. Here you can see there is a lesion in the middle phalanx of a finger of a digit, middle phalanx of a digit, where you can see a lytic lesion in the medullary cavity of the bone, medullary cavity of the bone. Okay, as we have already discussed, the enchondromas are more common in the bones of hands and feet, and their sharply defined scalloped margins may cause endosteal scalloping. You can see here that there is some kind of endosteal scalloping. Endosteal scalloping means the lesion, it erodes the cortex from the inside. It erodes the cortex from the inside, causing some scalloping. Okay, it is called endosteal scalloping. Okay, expansion of the overlying cortex may be present, but there should be cortical breakout unless fractured. Okay, there can be some punctate or popcorn calcification within the lesion. So here you can see that within the lesion there are some calcifications which are called popcorn calcifications, and there are no periosteal reaction. There is no periosteal reaction. So majority of enchondromas are more frequently in the metaphyseal regions. The cartilaginous lesion in the epiphyse is more likely to be chondrosarcoma. Okay. Here you can see another lytic lesion in the proximal phalanx of the digit. Here you can see that there is some kind of cortical breach here. Okay, here you can see there is a lesion, lytic lesion in the middle phalanx of the finger. Here you can see there is a cortical breach and also there is a pathological fracture. So solitary enchondromas of the hand, you can see that 40 to 50% of the enchondromas usually occur in the proximal phalanges, 30% in the metacarpals, 20 to 30% in the middle phalanges, 5 to 15% in distal phalanges, and less than 2% in the carpal bones. So imaging MRI is useful in evaluating the soft tissue extension. Enchondromas are usually well circumscribed. Okay, on the T1 it is intermediate to low signal. Okay, so on T2 it is high intensity on T2, and T1 it is intermediate to low signal. So here you can see that there is a high intensity lesion in the proximal phalanx of the digit, proximal phalanx of a digit. Okay, it is a high intensity lesion in the proximal phalanx of the index finger. This, you can see here that this is the index finger, this is the proximal phalanx, and here you can see that it is a expansile high intensity lesion at the base of the proximal phalanx. So now you can see Ollier's disease. Ollier's disease is a multiple enchondromas. Multiple enchondromas are Ollier's disease. Here you can see there are so many lytic lesions, lytic areas in the middle phalanx. This is the proximal phalanx, middle phalanx. Proximal phalanx, middle phalanx. Here you can see so many lytic lesions are there. So multiple enchondromas. Here also you can see in the metacarpal also. Here you can see that there are so many lytic lesions causing some endosteal scalloping here. Endosteal scalloping. Okay. So multiple enchondromas. It is called Ollier's disease. It is a non-hereditary sporadic skeletal disorder characterized by multiple enchondromas, principally located in the metaphyseal regions. Okay. Plain X-ray show multiple enchondromas. Larger lesions show cartilage calcification and typical rings and arc, ring and arc pattern. Okay. Maffucci syndrome is a congenital, non-hereditary mesodermal dysplasia characterized by multiple enchondromas and also with soft tissue hemangiomas, cavernous hemangiomas. So, multiple enchondromas is Ollier's. Multiple enchondromas with cavernous hemangiomas is Maffucci syndrome. Maffucci syndrome. See here you can see so many lytic lesions in the bones of hands and feet. In the bones of hands and feet, so many lytic lesions are there. This is a Maffucci syndrome, and in the Maffucci syndrome you can see so many cortical breach happening, and lesions are not necessarily medullary. It can also be eccentric lesions. Okay, but in the Ollier's disease you can see the lesions are mostly medullary lesions. This is a Maffucci syndrome and this is Ollier's disease. Chondroblastoma, as we have already discussed, we will proceed to cystic lesions of the bone. Next, we concentrate on bone forming tumors. Okay, so osteoid osteoma, it is most common in the second decade, more common in males than females. Most common is the proximal femur, tibia, and spine, not seen in bones of membranous origin. Okay, and it causes dull pain. It is worse at night. It is relieved by NSAIDs, non-steroidal anti-inflammatory drugs, and it is not related to any position or function. It is often aggravated by alcohol. So pain is elicited by local pressure. Okay, radiological findings are radiolucent nidus will be there in the lesion. There is a radiolucent nidus. Differential diagnosis is osteoblastoma, non-suppurative cortical osteomyelitis, and Brodie's abscess. Diagnosis is done by technetium bone scan. Also headlight in fog appearance and double density sign. CT, it's a bullseye appearance. On the CT you can make out a bullseye appearance. So here you can see that there is a cortical lesion. Osteoid osteoma is a cortical lesion. Cortical lesion. It's not a medullary lesion. So cortical lesion. This is a cortical lesion, and here you can see that there is a small radiolucent area which is called the nidus. Radiolucent nidus. This nidus is characteristic of osteoid osteoma. This nidus is a characteristic of osteoid osteoma. Here on the CT, you can see on the CT you can see here that there is a bull's eye appearance. Okay, so there is another lesion here, and there is a small radiolucent area here. Radiolucent area here. Okay, on the bone scan you can see that this radiolucent area has given rise to increased uptake on the bone scan. On the bone scan it is an increased uptake. So here you can see that we made a cortical window here, cortical window. Okay, okay. So pathology. So nidus has so many osteoblast and non-myelinated axons. So stroma has osteoblast, osteoclast, fibroblast, and blood-filled capillaries. They transform into osteoblastoma, but no malignant transformation. They are self-limiting lesions. Conservative treatment with NSAIDs. Surgery is to eradicate the pain-producing nidus. So methods are to en-bloc resection or burr down technique. Latest is percutaneous radiofrequency ablation. Next comes the osteoblastoma. Osteoblastoma is, it is similar to osteoid but it is a bigger in size. Bigger in size, more than 1 centimeter. Osteoid it is called osteoblastoma. Okay, radio is a nothing particularly distinct to well circumscribed lesion. On the CT, we get a cotton wool appearance. Cotton wool appearance. Okay, treatment is curettage bone grafting. Curettage bone grafting. Next, fibrous lesions. Fibrous lesions, non-ossifying fibroma, cortical desmoid, benign fibrous histiocytoma, fibrous dysplasia, and osteofibrous dysplasia. Non-ossifying fibroma, it is the most common musculoskeletal tumor, occurs 30% of the children, common in first 2 decades. Site is a femur and tibia and humerus. X-ray, it is well-defined eccentric lesion. Radiolucent metaphysis, okay, metaphysis lesion, and doesn't expand the cortex, and there is no periosteal reaction. Treatment is just observation because it is self-limiting lesion. So here you can see that there is a lesion here in the metaphysis. In the metaphysis there is a lesion here. It doesn't much give rise to a cortical expansion here. Okay, there is some kind of endosteal scalloping here. Okay, it is self-limiting lesion. It occurs in children. So fibrous dysplasia. Fibrous dysplasia is the intrinsic defect of endochondral bone formation. It is an immature ossification pattern characterized by replacement of normal bone and marrow by fibrous tissue. Okay, solitary or multifocal. Albright's syndrome. It is a polyostotic fibrous dysplasia with capillate spots with endocrinopathies. Masabrod syndrome. It is polyostotic fibrous dysplasia with intramuscular myxomas. Intramuscular myxomas. The syndromes which are associated with fibrous dysplasia are Kuhn-Albright syndrome and Masabrod syndrome. The site are one rib, femur, humerus, tibia, and maxilla. Clinical features: if monostotic, it is asymptomatic. Bone pain and deformities may be there. So radiographic features: one, it is more common in the epiphysis or metaphysis or diaphysis. It can occur anywhere. A well-defined geographical lesions, ground glass matrix, and secondary deformities might be there in weight-bearing bones. Like in the femur, it can give rise to shepherd crook deformity, shepherd crook deformities, because it can give rise to microfractures on the tension side of the bone. Okay, here you can see that there is a lytic lesion here, expansile lytic lesion in the metaphysis and extending into the epiphysis, epiphysio-metaphyseal lesion causing cortical breach here. Okay, cortical expansion here. Okay, shepherd crook deformity is most common in proximal femur. Proximal femur. Okay, see, this is shepherd crook deformity. Shepherd crook deformity. Okay. Treatment: monostotic fibrous dysplasia, asymptomatic, no treatment. Indication: severe deformity, persistent pain, and pathological fracture. Then these are the indications for surgical treatment. One we do is curettage and bone grafting, internal fixation with or without osteotomy, and bisphosphonates. Bisphosphonates. Okay. The rest of the benign lesions we can discuss in the next class. Okay. Thank you.